My name's Nicholas Crump. I'm a neurologist and neurophysiologist, and I'm going to be presenting on the interpretation of peripheral neurophysiological tests, particularly nerve conduction studies, but also some of the other tests we do in the neurophysiology lab. So the testing encompasses essentially nerve conduction studies and needle electromyography, or EMG. It's usually a part of more comprehensive neurological assessment, which involves both a history and examination, but oftentimes in a simple situation such as carpal tunnel, it'll be a very brief history and exam, and the majority of the consult will be based on the testing. There are some other specialised tests, but we'll be focusing mainly on the routine nerve conduction studies in this presentation. So really, people are referred for these tests, or should be referred for these tests, when they're suspected to be a neuromuscular disease. So that's a disease affecting the nerve root, the peripheral nerve, the neuromuscular junction, or the muscle itself. It's not for diseases of the central nervous system in general. It's not for diseases affecting musculoskeletal problems such as more joint problems. And it's obviously can be helpful in ruling out these possibilities when there might be felt to be another underlying diagnosis, but really they are designed around the neuromuscular system. So as a result, they diagnose neuromuscular diseases, and the outcomes we can get can be that there's no problem within the neuromuscular system. There can be problems at the level of the root, a radiculopathy, the various plexi in the upper and lower limbs, in the peripheral nerve itself, either in a generalized or focal pattern, in the muscle itself, a myopathy. There can also be other slightly different localizations, such as widespread motor axonal problems, such as seen in motor neuron disease, and disorders of neuromuscular transmission, in particular myasthenia gravis. As well as helping to localize within an anatomical area, these tests can give ideas about the time course disease, the acuity versus chronicity, the distribution, whether it's a generalized process, an asymmetric process, or a focal process, and also some indication on the severity of the disease. And here's a list of the multiple possibilities that we can evaluate with nerve conduction studies and EMG. As alluded to, these tests are not particularly helpful in positive diagnosis, but occasionally helpful in ruling things out in the situations of joint diseases, fibromyalgia and myofascial pain syndromes, where I guess the testing really is done to see that it is normal. Disorders arising from the central nervous system, from the spinal cord, or from the brain. So this is the basic setup of the testing. There's usually a computer-based workstation. Electric impulses are applied through a stimulator, and then we receive the responses back via a digital analog amplifier, and that brings up some results on a computerized oscilloscope, essentially. Nerve conduction studies are the mainstay of the testing, and what we do with routine studies is provide a supramaximal response to the peripheral nerves in order to generate a response. The nature of the anatomy of the nervous system and the limitations of giving electrostimulations through the skin rather than directed more deeply is such that the test can only really usefully be done for nerves that can be easily accessed, and so that essentially is confined to below the elbows and below, around the elbows and below, and from the knees and below. We can do some more proximal stimulation, such as in Erb's point in the neck, or occasionally in the groin, but these are more difficult. Recording from proximal muscles which are larger is also more difficult. They are a bigger target with more dispersed responses. So we're really focused on looking at the responses coming from smaller muscles, such as those in the hands and the feet. Essentially, the nerves being excitable membranes which work by the progression of action potentials means that they're excitable membranes, and so provision of an external stimulus will depolarize the nerve membrane and initiate an action potential, which will then travel down the nerve as a normal internally generated action potential will. When we stimulate as many of the axons as possible, that's what provides the supramaximal response that we use as the basis of our recording. So these recordings thus are really more around the entirety of the integrity of the nerve rather than specific axonal function or excitability. As a result, these tests mainly look at large myelinated fibres, which are the fastest conducting, because they will swamp the response of the smaller myelinated fibres or unmyelinated fibres that will respond much slower in a much more dispersed fashion. So the understanding of these concepts gives some idea of some of the deficiency of the testing, particularly looking at problems where there might be in unmyelinated fibres, which can be particularly aspect in pain situation, which often involves the small or unmyelinated fibres. So this is an example of what we do in doing a median nerve study at the wrist. So we provide electrical stimulus. The current, by convention, obviously the current will flow from the cathode, and so we supply this at the closest point over the median nerve at the wrist. We then make direct recordings over the muscle from the thenar eminence, which we'll call abductor pollicis brevis, but it's probably more the median nervated muscles of that group. And we have a reference electrode over bony prominence and the active electrode over the muscle. And then we stimulate the nerve both at the wrist in a distal sense, and in this situation we do a proximal stimulation at the elbow. And this will then provide these responses, which can be seen here, where we get a fairly similar response. It should ideally be identical, but for technical reasons there can be some mild deterioration in the response over a longer segment of nerve. But we get these responses recorded. From these recordings we can measure a number of direct parameters that allows us to tell about the integrity of the nerve, both within this section recorded, but also in a more generalised sense. And so then with a cartoon of what we're actually doing at a more anatomical level, we're providing the stimulus over the motor axon itself, although what we're really stimulating is the multitude of axons rather than one. We're then getting saltatory conduction down the myelinated axon, crossing of the neuromuscular junction with acetylcholine, and then subsequent muscle contraction. So what we're recording is the electrical activity in the muscle in a motor study, not in the nerve itself. And so this shows the way that the action potential moves down the axon, and obviously we have some hyperpolarization behind such that we get minimal stimulation in the opposite direction. So what we record in a motor study is this electrical activity in the muscle, the compound motor action potential. The sensory studies are different. We're recording directly nerve to nerve, so we get what's called the sensory nerve action potential. There are also some longer reflexes, which I'll briefly mention, an F wave and a H reflex. As mentioned, it's assessing large myelinated fibres only. The small or unmyelinated fibres are not accurately recorded, or not really recorded at all with these studies. And what we assess for is the presence of an axonal problem so the nerve fibres directly, or whether there's a focal or demyelinating process in which we look for different kinds of changes. The parameters we'll mention will make more sense as we look through an example, but the main things we look at are the distal motor latency, which is the time it takes from providing the electrical stimulation to the initiation of the onset of muscle contraction. And basically this is determined by how quickly it takes the nerve response to go from where you stimulate down the nerve, the conduction velocity. Then also the transmission time of the response across the neuromuscular junction, and then the initiation within the muscle itself. We then also look at the amplitude, and this is directly correlated to how many muscle fibres are activated, and which is directly correlated to the number of motor axons that are intact. Then we also look at the conduction velocity, and this is determined by, we measure we determine the latency between the proximal and distal stimulation points, and then we work out the distance and use that to derive time taken, and of the time taken then we can initiate a velocity. And so the drops in velocity are a marker of demyelinating neuropathies, and we'll go through the examples, which makes a bit more sense with this. So this is a normal median motor study, similar to the example showed before. And the parameters, as mentioned before, the distal motor latency is the time taken to this point here. In this case, it's 3.2 milliseconds, which is very normal. Anything less than 4.5 is normal. We then have the amplitude, and so that's the maximal height of the response. So from the baseline to this maximal point. And in this case, the amplitude is 15 millivolts. Again, very normal. Anything above 5 millivolts is normal from adult median motor response. We then look at the amplitude between the proximal site at the wrist and the distal site at the elbow. And again, the amplitude's well preserved, as is the case in a normal study. And then by determining this latency between the distal motor latency and then the more proximal motor latency divided into the distance gives us a conduction velocity, which in this example is completely normal. Anything above 48 milliseconds, or anything above 48 meters per second is normal. So this is a real-life example of a test I've actually performed, and this is an initial response from a right median motor study, in which case the amplitude looks small, and so you may be suspicious that there's, when we have problems with reduced amplitude, there might be an axonal problem here. But in fact, what the issue is here is this is not supermaximally stimulated. So we haven't depolarized all the axons, and so not all the motor units are activated. And so this is a technical issue which means that we have to very carefully pay attention to what we're doing in the test and make sure that we're over the nerve directly, recording over the muscle appropriately, and stimulated sufficiently enough to give a maximal response. Otherwise, you could give a result like this from a test and tell someone there's a problem that isn't actually there. So then when actually turn the stimulus up a bit higher, we get a much better response. So looking at the parameters mentioned, the distal motor latency is 3.5, completely normal, and the amplitude is 6.8, again, very normal. So very important to get the supermaximal response to get the best possible outcome. This is what is the true measurable response. And again, we've got the amplitude, which indicates how many motor units and axons you're able to stimulate, and the distal latency determining the time taken. We then go on and do the more proximal stimulation at the elbow. And again, the things to look at when we do the proximal stimulation is there significant drop in the amplitude. Anything up to 20% in the upper limbs is probably going to be normal, and so this is not a significant drop. And then by determining the difference in the latency, so 7.3 minus 3.5, and then divided into the distance measured here in centimetres at about 23 centimetres across the forearm, it gives us a conduction velocity of nearly 60 metres per second, which is well and truly normal. So from these parameters we can determine quite quickly this is a normal right median motor study with a normal distal latency, normal amplitude, no drop in the amplitude between the sites, and normal conduction velocity. And then this, so what we present in the reports when we do these tests is those numbers and summarising those factors quite quickly. The graphs are usually not included, but occasionally can be if they're felt to be of relevance. Sensory studies are slightly different in that we don't have to deal with neuromuscular junction transmission or time taken for the motor response to activate. So we can determine velocities immediately from a single stimulation point. And what we generally do is stimulate the nerve in an orthodromic fashion, so that is the same way as normal sensory fibres conduct. So we stimulate in the periphery. In this example, it's a digit 2 response. In this case, we stimulate with rings around the fingers, and then recording up at directly over the peripheral nerve itself. So in this case, a median digit 2, we're recording at the wrist. Important points in the anatomy of the sensory nerve is that the cell body of a sensory nerve is not in the spinal cord, as is the case in a motor study, but in the dorsal root ganglion, which is outside the spinal cord. I'll mention why this is important in this slide here. In that, if there's no lesion, of course, we get a normal response as you would expect. If the damage, however, is before the dorsal root ganglion, as would be the case in most radiculopathies, where if there's a disc bulge and pressure on the exiting nerve root, but before it's on the dorsal root ganglion, there'll be no sensation as the response doesn't come through to the spinal cord here in this cartoon. But because the cell body is intact and thus all the axons will remain intact, there'll be no degeneration of the nerve response. So thus nerve conduction stays very important in determining radiculopathy versus peripheral nerve problem, with whether there's or not the presence or absence of the peripheral sensory response. If the damage is after the ganglion, as with a peripheral nerve problem, we'll then get degeneration of the axons and thus a reduction of the amplitude or loss of the amplitude of these sensory responses. And so this is in real life what happens with the responses. We stimulate the digital nerves which run down the sides of the fingers with these rings, and then record directly over the peripheral nerve itself, in this case at the wrist. And these are examples of the responses we're seeing. The important thing about sensory responses is that there's a lot more technical factors. The responses are in microvolts rather than millivolts for the motor studies. As a result, technical factors, poor skin preparation, electrical interference around the room, and other factors can interact with it quite greatly. So it does make it a more difficult part of the test to do, and thus a more difficult part of the test to interpret. Much the same with motor studies, we record similar responses. We record latencies, velocities, and amplitude. The latencies and velocities, the time-based parameters, are really around sort of issues with myelin, and the amplitude is really determined by number of axons intact, and so thus, if reduced, reflects generally axonal problems. And so this is a normal median sensory study. Again, as mentioned, beware that the amplitudes are much smaller, but we see that in this case we've got this is a very normal response from a digit 2, and the conduction velocity is well and truly normal. The velocity is much the same in the upper limbs. Anything above sort of the high 40s is definitely normal. So this is the case before, where we had the normal motor study. In this case we show the digit 2 median study here, and the latency is 2.6 and the conduction velocity is fairly good. The amplitude is 8.5, which for an orthodromic study is well and truly normal. Anything above 6, as mentioned there, is normal. You can alternatively do nerve conduction studies measuring the alternate way, so stimulating over the nerve and recording in the periphery. That gives better amplitude responses, but also has the problems with receiving motor artifact, in that you're stimulating the nerve the same way as you would to generate a motor response. So there's pros and cons, but most people tend to do things orthodromically these days. So this is the example mentioned before, but including a wider array of studies, including the digit 5 response from the ulnar nerve, as well as a comparison study in the digit 1 responses in the median nerve versus the radial nerve, and then also the digit 4 responses, which are split between the median and ulnar aspect. And again, the recordings are, as mentioned before, the amplitude, the latencies and velocities, indicating both in amplitude axonal problems and latencies, velocities, demyelinating problems. Late responses, as mentioned briefly, essentially there's two types. The F wave is not a true reflex. It's essentially when you stimulate the nerve in the periphery, whilst we're recording what happens in a orthodromic fashion, in a descending to the periphery. A response does fire back up the nerve, up towards the spinal cord. A response will then bounce back in a subset of the motor neurons and then lead to a later response from within the muscle, and this is called the F response. This is a fairly helpful but crude way of assessing the entirety of the nerve length, so it can be helpful in more proximal nerve problems such as radiculopathy. The H reflex, by contrast, is a true reflex where we stimulate the afferents to the muscle spindles, as you would do when you're doing a tendon reflex. You then directly record the motor responses coming back down the motor nerve appropriately, not some firing back response. This is particularly helpful in the legs, but you can do a H reflex on any muscle, but it does involve some technical aspects that are a bit harder in terms of getting the patients to be relaxed enough or having enough mild activation to prevent it being masked. So F waves are much more routinely done, and what we basically do is put the screen on a much wider sweep speed, and when we see here the stimulus artifact, and then we get the initial response, and this is called the M response. This is our actual CMAP. This is what we normally record doing the motor study. But then after a delay, we see a family of responses. The CMAPs being supramaximal by definition will be identical because this is the best response you can get, and thus once you get it, it should look the same every time. But these F waves are very different. They're much smaller, so because a different subset of the motor neurons fire back every time. But essentially the latency should be fairly consistent, and it's this earliest or most consistent latency that's what we use. And basically there's normal values according to the height of the patient that can determine whether this latency is prolonged or not. F waves can also be useful if they're definitely absent in someone who has a normal CMAP. It suggests there might be an underlying problem with the peripheral nerve at an earlier stage, given that you really should expect to see some responses. So we generate these figures. It sounds like lots of numbers, but there's actually a fairly simple way to look through them if you are reading through reports. And it's just a matter of looking at the parameters one by one, and particularly in motor nerve studies, and in sensory studies it's similar but slightly easier. The first thing to look at is the amplitude reduced distally? If it is, you then need to look at, is the distal latency very prolonged or not? If it's very prolonged, it suggests that there's a marked problem with demyelination distal to where you stimulate. So that can be in a severe case of carpal tunnel, for example, or another demyelinating process. If the amplitude's quite reduced but the latency is fairly much in the normal range, then what you've got is you've lost axons, and it suggests that there's an axonal process affecting that nerve. If the amplitude is normal, the next thing you then look at is the latency. If the latency is prolonged, then what you've got is a demyelinating lesion distal to where you've stimulated. If the amplitude's normal and the latency is normal, we then go up. Is there any drop in the amplitude between the distal and proximal site, or is there any conduction slowing? If not, it's a normal study. If yes, then what we've got is a focal demyelinating lesion between the sites you've recorded rather than distally. You do that for the various nerves, motor and sensory, and put things together, and what we find is the general pattern we look at, it will be that it's normal. The next thing will be there may be a focal lesion. The other processes may be is that you've got generalized axonal changes, so you've got reduced amplitudes with relatively normal latencies and velocities, and that is the general pattern of an axonal peripheral neuropathy seen with diabetes and various other conditions. If we see focal demyelinating changes in one place, in one nerve, then what we have is a focal neuropathy, such as a carpal tunnel syndrome or an ulnar neuropathy of the elbow. If we see the rarer outcome of multiple demyelinating changes in different nerves, in different locations, what we've got is a demyelinating peripheral neuropathy. So just putting the numbers up of the case we demonstrated through before. We have the motor study, again as mentioned, is normal. A normal distal latency, a normal distal amplitude, no drop, and normal velocity. The sensory studies you have to look slightly differently at. We do look at the latencies, especially in the amplitudes. In this case, however, the amplitudes are all are normal. The digit responses from the digit 5 from the ulnar and the rail digit 1 should be more than 4. They're normal, and the median digit 2 stage should be more than 6. So all definitely normal. What we need to look at though are the latencies. And so in this case, often what we do is there'll be normal values, but what's more important is comparing patients side to side or comparing from one nerve to the other over the same distance. In this case, what we see is there is a slight difference in the digit 1 latency in the median versus the radial. A more marked difference though on the digit 4 comparison. This is more than 1 millisecond. Anything more than 0.5 millisecond is abnormal. We then also have a slightly different response, the Palmer response, which is much like a sensory response. Again, should be 0.45 or less. The difference here is 0.55. And this patient is referred for the main reason someone gets sent for nerve conduction studies with some intermittent paresthesia in the right hand, especially at night. And so these minor differences on latencies equivalent to a diagnosis of median neuropathy at wrist or carpal tunnel syndrome. This case has a normal ulnar motor study and a normal median motor study, as is normally the case. If people have had the case longer or more severely affected, they might have some change in the motor studies, particularly prolonged distal latencies, and then as it gets worse, they may drop their motor amplitudes. But the main thing we see is the slowing, usually relative rather than marked specific slowing of the median nerve responses across the wrist. And the reason we see these demyelinating changes is because it's a focal compressive neuropathy with focal demyelinating changes. And the treatment of carpal tunnel obviously ranges from splints through to surgery. So this is really one of the main things we do in nerve conduction studies, is define and localise focal neuropathies, but we also look at more generalised neuropathies, and we'll go through a couple of cases now. First is a middle-aged older middle-aged gentleman with diabetes and previously drunk a lot of alcohol, who now presents with some pins and needles in his toes that slowly progressed up to his foot. He's also describing some mild problems with weakness, with balance, but he's not noticed any weakness. And this is a fairly typical presentation of someone with peripheral neuropathy who gets sent for nerve conduction studies. Then presented some isolated data of relevant nerves. So again, just working through the parameters in this ulnar motor study, we first look at the distal amplitude. This is normal at 5.4 millivolts. We then look at the latency, and then at 3.2 milliseconds, again it's normal. We then look and see is there any drop in the amplitude up the study, and there's a mild drop across the sites, but again not at the 20% range that we'd consider significant. We then look at the conduction velocities, and they're sort of just either side of being normal, and so essentially pretty unremarkable. So it's essentially a normal motor study, nothing of concern. We then go on and look at the sensory responses, however, and we can see that the amplitudes of the ulnar study is 2.3, whereas it should be more than 4, and the radial likewise is a bit reduced. So what we've got is reduction in the sensory amplitudes. And they're very suggestive there might be some axonal problem here. We then go into this lower limb studies, where this time the tibial motor response, we've got a normal, we've got a reduced amplitude, should be greater than 2, but this time it's 1.2 millivolts. And the distal motor latency is slightly prolonged. And this is an important point, that we go, oh, well, that might be focal demyelination, but what we've really got is only a very mild prolongation, not particularly marked. What's more marked is nearly 50% from the below the lower limit of normal. So it's the most prominent finding we should be looking at. And so the amplitude drop is more of a standout feature than the mild prolongation of distal latency. There's no real drop across the distal and proximal sites, and the conduction velocity is essentially within the just at the bottom of the normal range. So what we've got is some axonal features in this tibial motor study. And then we've lost the sural sensory response from that same leg. So it's obviously zero amplitude is as low as it can get. So again, featuring, so all these factors together fit with an axonal process worse in the legs and the arms. And this is your fairly typical length-dependent axonal neuropathy. And so just to mention it again, what we see is reduced amplitudes. The velocities are generally preserved, but they might be slightly slow. And the latencies are generally preserved, but they might be slightly long. But again, it's the relative pattern of that. It's more about amplitude drop than the velocities and latencies. And the list of things that cause this are long. This typical pattern we see. It's mainly diabetes and other toxic exposures in our community. But the list here of some of the possibilities to consider. So obviously diabetes is the most important and clearly the most prevalent. B12 is one important thing to look for because it's eminently treatable. And hopefully most of the other parameters should be evident from history or some simple investigations. The alternate presentation, though, is of someone with a slightly different story of peripheral neuropathy. And this is a man of the same age, but with no past medical history. This time they've noticed problems with some numbness in the feet, but also a little bit in the hands, and a little bit of weakness too this time. And what's noticed is that when you examine this person, they've got no reflexes in the legs and reduced in the arms, so a bit more prominence of the reflex loss, and not just a distal problem. And rather than going through a whole list of numbers this time, just mentioning some of the the important findings, that this time what we've got is normal amplitudes. They're a little bit reduced in the legs, but in the hands they are normal, but the latencies are prolonged. The conduction velocities are slowed, below 40 meters per second in the upper limb, so definitely slow, not just a little bit. The F-wave latencies, markers of the entirety of the nerve, are prolonged. And what we see is conduction block, which is where you'd see a drop in the amplitude across sites. And the sensory studies show amplitudes are preserved, much like the motor responses, but with some slower velocities. So in this case, the diagnosis is very different. And just to show an example of what conduction block shows, coming up from, in this median motor study, we come from the wrist, then we go further up the arm, and we start to see this drop in amplitude. And then as we come further up to the elbow, we see not only is the amplitude drop, but it's become quite dispersed. So this suggests there's quite a bit of variability in the conduction in the forearm segment between the elbow and the wrist. This is true conduction block, and this is what we see with demyelinating neuropathies. And this is the example of the F waves, where before in a motor study they would normally all appear here at about sort of 30 milliseconds. Instead, what we're getting is marked dispersion with them appearing at very prolonged periods of time. So this is a demyelinating neuropathy. This is quite a severe one in this example, where the distal latency is almost 5 times the upper limit of normal. What you need to notice here, though, is the amplitude is very small, but this you need to be this is not an axonal problem, because the distal latency is so prolonged it tells us there's definitely a demyelinating problem, and what we're actually seeing here is conduction block, and that's why the amplitude is reduced. But just again to summarise, demyelinating, what we're seeing is prolonged distal latencies, generally preserved distal amplitudes, slowing of conduction, block of conduction, and dispersion of the responses between the distal and proximal sites. Demyelinating neuropathy is important to diagnose for a number of reasons. Their differential diagnosis list is quite different, and some of them, in particular the acquired immune demyelinating neuropathies, are treatable. So obviously in acute situation it's AIDP or Guillain-Barré syndrome, and chronically we get CIDP and its various variants. There are a number of other potential causes, most of which are pretty unusual to see in terms of toxic or infectious exposures. But the main other thing that we'd be looking for in demyelinating neuropathies would be the presence of it being an inherited condition. Moving on from nerve conduction studies now briefly onto needle EMG. This is where we insert a small needle which acts as an electrode into the muscle and records the electrical activity in the muscle. It's important to be aware it records the electrical activity, not any mechanical force or any other biochemical parameters. It's just recording the electrical activity. We use a small needle. It's generally pretty well tolerated by patients having it done. We test a number of muscles in a way to answer a specific clinical question, as opposed to nerve conduction studies, which are done fairly routinely from one patient to the next, depending on what we're looking for. EMG is much more tailored, and so really requires a good understanding of what the question to be answered is. There's hundreds of muscles you can potentially test, and patients will get very sick of you if you do too many. What we look for is really both muscle activity at rest, which in a normal case there is no electrical activity, and then what happens with voluntary contraction. And what we're then looking at then is what's called the motor unit action potential, which is the electrical activity within a group of muscle fibers that are innervated by one axon. That's the motor unit. And the difference, the morphology and the characteristics of this allow us to determine what sort of muscle problem there may be, or nerve problem there may be. So this is just an example of what we do. Gloved hand. It's a very fine needle. This is into APB, which is not a great example to show because it's one of the more painful muscles to test. But essentially, when we put it at rest, we may see a brief blip of insertional activity, but then we should see otherwise a flat baseline, nothing happening. At rest, what we look for is called spontaneous activity, and what we look for is really the absence of any. The things we'll commonly see are fibrillation potentials and positive sharp waves, which are signs of irritated muscle fibre, and it's usually a sign of denervation. And so the muscle fibres fire off spontaneously because they're denervated. Fasciculations, however, are spontaneous activity within motor units. So these are things that patients may see, but they also can a much larger response because it's due to a direct problem with either irritable axons directly rather than irritable muscle fibres, and so they're much larger and look like a motor unit just firing by themselves. These changes, complex repetitive discharges, myokymia and myotonia, are much less common spontaneous changes, but are characteristics seen by electromyographers and help diagnose things more specifically. CRDs are present in very prolonged or chronic neurogenic conditions. Myokymia is very uncommon and seen with radiation-induced damage, and myotonia, which is a very unusual pattern of muscle fibre activity, is seen with the myotonic conditions, in particular myotonic dystrophy. I'll just briefly show an example of some spontaneous activity because the video makes much more sense than a picture. And this is a fibrillation potential and a positive sharp wave. And this shows that normal muscle at rest, nothing should be happening. And what we're then seeing is these brief discharges, very narrow, very small, So these are muscle fibers firing by themselves. And basic fibrillation's positive sharp wave is the same, but you can see basically a positive sharp wave is just where there's no upwards movement. In neurophysiology, negative is up and positive is down, just to confuse matters. But that just shows that there's these brief popping discharges from irritated muscle fibers, usually denervated. Fasciculations, by contrast, are slightly different. They're bigger because they're a whole motor unit, not just a single muscle fiber. And so this person's resting, and then we're seeing these usually individual lesions firing off by themselves. On the frozen trace down here, it also demonstrates that these fasciculations are coming from a denervated motor unit or reinnervated motor unit. And I'll mention it briefly a bit later, but these units are much bigger than they should be. They're longer duration and they're polyphasic. And this is a sign of denervation reinnervation. And finally, this is myotonia, which is very characteristic, said to be like a dive bomber, but it's probably more like a revving motorcycle up and down, where you get a crescendo decrescendo firing. So those are single muscle fibers firing off at a very rapid rate. The exact reason why it happens in myotonic dystrophy is unknown. Some of the other myotonic conditions, essentially, they're related to channelopathy, so they're hyperexcitable muscle fiber membranes. When we actually test the muscle when it's moving, we're looking at two aspects of motor unit at the motor unit. We're looking at its configuration, and we're looking at the pattern of recruitment. In the configuration, without going into too many details, what we look at is the amplitude, the morphology, and the duration. And to break it into three patterns: normal motor units, neuropathic motor units or reinnervated motor units, where we get high amplitude, long duration, polyphasic units, or myopathic, where we get low amplitude, short duration, polyphasic. And I'll explain briefly how this comes about in the next slide. We then also look at recruitment and interference pattern. And essentially, when you activate a muscle through various levels of strength, the force principle is such that at low levels of activity, you use smaller axons to fire smaller motor units. And then as you increase force, you increase the firing frequency of the motor units already in play, but then you recruit extra motor units, bigger motor units, to create more force. So as a result, what you see is a gradation from smaller motor units through to larger motor units with increasing degrees of force. Abnormalities of this pattern of recruitment can be seen either with myopathic or neuropathic conditions. And so we get essentially similar again, three patterns where we have normal, where we have a graded recruitment from smaller to larger motor units, and the units themselves look normal. We have reduced recruitment where, because there's loss of axons in a neuropathic condition, larger units fire earlier than they should. And you don't fill up because you haven't got enough axons to maintain force, and this is why there is weakness. In myopathic conditions are different because the nerves are intact, but what's wrong is the end organ, the muscle. Essentially, to create lower levels of force, the motor axons have to fire faster and quicker and earlier than they should to create the same level of force. So that's what we see as an early fill-up in the pattern, basically because there's just loss of the muscle fiber. Recruitment and the interference pattern analysis is really dependent on effort. Spontaneous activity is usually well tolerated by patients, but with the needle in a moving muscle, that's where they tend to have problems. So if people have got a central problem, like a stroke, effort, factitious problems, or if it's hurting and they can't do it, that will really affect your ability to assess the recruitment. So just in cartoon form, why there's a difference in motor unit morphology on EMG. Essentially, a motor unit consists of a motor axon and its branches to various muscle fibers. And so this is in this example, it's normal. And so when we record the electrical activity from all these muscle fibers together, it gives a bit of a complex form, which looks like this. In a neuropathic condition, what you'll have is loss of the axons on either side. So the intact axons then sprout out and provide branches to the muscle fibers to try to maintain function. So as a result, this motor unit essentially has got twice as big. And as well as getting bigger, it's more disorganized. These new branches are not as well myelinated or is not as mature. So what we get is a variety of times in conduction, and we get a bigger unit, so it's both a longer duration, a bigger amplitude, and because it's a bit more disorganized, we see more variability and polyphasia. In a myopathic condition, it's different. We've lost muscle fibers, whereas the axons are normal. But what we essentially get is the units are smaller. They're shorter and not as big amplitude. And because there's some irritability in the muscle fibers and their firing's not so regular, we do see some irregularity, this polyphasia, so the up and down. An example of EMG, and the parameters may be mentioned in the report. So we've got a woman who's got some difficulty with walking, who's got reduced amplitude EMG responses. There's some polyphasia, as mentioned before. It's a sign, a bit of a non-specific sign, but does indicate a problem. There's early recruitment, as mentioned before, and there's no fibrillations. So these EMG findings are most consistent with myopathy. In myopathy, EMG can occasionally be a bit hit and miss for a number of reasons. You sample a very small area of muscle, and so it's good for neuropathic conditions which tend to have more widespread distribution by units, but myopathic changes can be more anatomically discrete, so you might miss changes. There's also some myopathic conditions which don't have many EMG changes, such as steroid myopathy. But EMG can be helpful in terms of excluding a significant muscle problem, working out involved muscles, particularly for guiding biopsy, grading severity. It can give something about the pathophysiology. If you see myotonic discharges, it gives you a really good clue as to diagnosis. The presence of lots of fibrillations, which suggests there's a lot of muscle fibre breakdown, and usually a more active kind of process like an inflammatory myopathy. This slide I can let you look through later, but essentially goes through the ways that which we can use both the morphology and firing pattern of the muscle unit action potentials to try to summarise what might be happening. These tests are things we do apart from routine nerve conduction studies and EMG, which can involve usually more in research settings or more specialised testing. But the things that we can occasionally do more regularly are repetitive nerve stimulation and single fibre and EMG analysis. These are particularly helpful in myasthenia gravis. And evoked potentials can be a sort of a bit of a crossover with the central nervous system, but largely replaced by MRI. Neuromuscular junction testing. Essentially, what happens in these conditions, particularly myasthenia gravis, is that a relative problem with the acetylcholine transmission system is such that normally we have a safety factor. We release much more acetylcholine than we need to generate a motor action potential and thus muscle contraction and force. But if people have got a problem with that system, they reduce they've got enough maybe on the first release or the second release, but it starts to drop off. And so thus when you do high firing rates to maintain normal volitional activity, people get weak, but we can actually do that by repetitively stimulating the nerve in a way that we see deterioration. And so the main thing we do is what's called rep stim, where we give low frequency stimulations, and then generally after the third or fourth stimulation in someone with neuromuscular problem, we'll see a decrement in their response because basically they've run out of acetylcholine, they don't generate motor action potentials and their muscle action potentials, and thus they don't generate measurable CMAP. Single fibre EMG is a completely different technique, usually looking at more the irritability or variability in the difference between the muscle, the time it takes for one muscle fibre to fire relative to another within a motor unit. Now normally these should be fairly linked together within a single motor unit. They are designed to fire together. But if there's a problem with neuromuscular transmission, there'll be a variability in this. The variability is what we call jitter, and that's what we look for on testing. In terms of rep stim though, essentially if we stimulate a normal person, because of the safety factor acetylcholine, recycling of the acetylcholine and the changes in calcium flux that allow more efficient use of the acetylcholine, you can stimulate someone at low frequencies for as long as they could tolerate it, and there would be no change in the CMAP. So essentially what we've got here is a CMAP, then repetitive one, a further one, and there's basically no change in the amplitude across time. And that would continue as long as you did it. In someone with myasthenia gravis, however, the acetylcholine quickly runs out. So what we see is the amplitude of the responses drop, usually maximally by the third or the fourth, before you start to see a bit of recovery towards the end of a trade of 10. And that's because you start to see the changes in calcium mean and acetyl choline recycling mean there is some slight recovery. And so this, if seen at what we call a decrement, from the maximum amplitude to the minimum amplitude. If it's less than 20%, we call a decrement, but sometimes even if it's around 10% in an appropriate clinical situation, this is diagnostic of myasthenia gravis. Evoked potentials are slightly different. What they essentially are is a limited EEG, so we're recording activity over the spinal cord and brain, then providing a peripheral stimulation. And that could be a visual stimulation, such as an alternating checkerboard in the visual fields. You can give clicks and sounds to give a brainstem evoked auto response through the cochlear nerve, or we can give an electrical response in the hand or foot, and then record a somatosensory evoked response. What we mainly look for is for delays. So these things were very helpful in the diagnosis of central demyelinating disorders before there was MRI. We can also see if there's asymmetry of the responses or a blunting of the response. And the amplitudes can occasionally be of relevance. This is probably more so in SSEPs when done if they're bilaterally absent in someone who's unconscious in ICU. At 3 days they've shown to be 100% predictive of a poor outcome. But because of MRI and much better ways of looking at central nervous system problems now, they've largely dropped out of widespread clinical use. So coming back to the main point of the talk again now is that how looking at nerve conductions and how you interpret them. Again, the parameters to look at, the amplitude, if it's really reduced, if it's either compared to normal values or even if it's just relative to the other side. You're looking at either an axonal lesion, most likely, or occasionally that there's a conduction block and demyelination distal to where you're stimulated. Then it's on to the latency. If it's very prolonged, then it suggests there's a conduction block distally, a focal demyelinating process. But occasionally, if it's only mildly prolonged, it could be that there's just such severe axonal loss that you've lost the fastest conducting fibers, and so there's some mild slowing. But again, that should usually be mild and relative. We then look at the proximal amplitude, if there's been any drop of it, to suggest conduction block, and the proximal conduction velocity to see if there's any focal slowing. And then as well as those main parameters to look at from the numbers, we look at the quality of the responses, whether there's any prolongation or dispersion, to again suggest there might be conduction block. Understanding these parameters together allows us to group things into axonal processes where we have reduced distal amplitude and preserved conduction velocities. And this shows some slowing from the loss of, and this, as said, will be the general pattern we see. Demyelinating processes are different in that we generally have some relative preservation of the distal amplitudes, but we get prolonged latencies, slowed velocities, and we'll see occasionally blocks of conduction. And then, as well as looking at whether there's axonal or demyelinating features, we then look at, is it a focal process, a mononeuropathy, is it a symmetrical, asymmetrical process, or a generalized process? And so that's the end of the talk, but I just might run through one more case just to go through the parameters just one final time. This is a gentleman who presents with some sensory disturbance in the right little finger and half of the ring finger. Also notice some reduction in the grip strength. So the nerve conduction studies are presented here, and so again we'll just go through the parameters as mentioned before. We look at the distal amplitude at 9.2 in an ulnar. It's greater than 5, it's very much normal. The distal motor latency is 2.45, sort of less than 3.5 to 4, again very normal. So then what we look at is the amplitude as we come up the nerve. So from the wrist to below the elbow site, there's no change and the conduction velocity is normal. But then as we go across the elbow, from below the elbow to above the elbow, we get a marked drop in the amplitude. This isn't just a little bit, this is dropped by nearly 80%, or getting 60 to 70%. Associated with this drop in amplitude is a slowing of the conduction. Definitely slowing. This is not 49, this is clearly slowed, much slower than the other segment. So this is clearly what we mean by conduction block, where there's a marked drop of the amplitude with associated slowing. We then go on and look at the study on the alternate arm, the unaffected arm, and between the wrist and above the elbow there's no drop in the amplitude, and the conduction velocity is normal. We then look at the sensory responses, and so the patient's got sensory symptoms here, but what we'll note is that the amplitude of the response is actually 8 microvolts, which is basically the same as the other side. So despite having sensory complaints, there's no drop in the sensory response. So that might make you wonder what's going on, but essentially it shouldn't, because what we've got here is a definite ulnar neuropathy at the elbow, and this is quite common. It's probably the second most common thing we would check in the lab after carpal tunnel. And the location of the compression can be, or damage can be, a bit variable. It can be at the ulnar groove, and as we know, the nerve's quite superficial, and a lot of people have got a shallow groove which the nerve can sublux, or it can be compressed as it passes under the tendinous arch formed by the sort of aponeurosis of flexor carpi ulnaris, and that's the cubital tunnel. It's not uncommon to have more motor than sensory problems. People often present more with weakness of the hand rather than noticing the numbness. What we're looking for on the testing in this case, as in this case, is conduction block, and we've found quite classical change on this example. And that's where we get the drop in the amplitude along with the associated slowing. You may not see such marked changes. It might not localise so well. You might see more degenerative axonal change, particularly if it's more long-standing. So there are certainly some not always such easily diagnosed. The other thing to point out is why the amplitude is normal is because the problem is just at the elbow. What we've got is conduction block and a demyelinating process. But what we don't have is any serious axonal damage. And so because the axons are not damaged, this is why we've still got a good amplitude of the motor response at the wrist, from stimulate the wrist. And this is also why we don't have any drop in the sensory response when recording in a distal sense. The axons are intact, the cell body's intact, there's no Wallerian degeneration, and so amplitudes don't drop. What we've in fact will have, is the reason there's numbness, is much like there's motor conduction block here. If we went and did a sensory study ascending up the arm, we would also likely see a similar feature. You don't see conduction block in sensory studies like that, but what you will see is focal slowing. So essentially responses aren't getting through the elbow. The nerves are intact, but because there's demyelination, a loss of saltatory conduction, basically the responses don't get through and there's numbness, even though the wires themselves, the axons, are fine. So I think that's probably enough examples. There's more examples there listed in the syllabus if you want to look through and work through yourself, but I hope that gives you a bit of a framework and basis of which to look at nerve conduction studies, and a bit of understanding of what their roles might be and some of the ups and downs with testing. So thanks for your attention.